Hey, welcome to The Explainer. If you or someone you know has type 2 diabetes, get ready, because everything you thought you knew about how we treat it is changing, and changing fast. We are right in the middle of a genuine revolution. The entire goal has shifted from just, managing blood sugar to actively protecting our most vital organs. So let's dive in and break down exactly how this happened and what it means for millions of people.
Yeah, this quote right here, it just nails the new reality. For decades, the main target, the bullseye for diabetes treatment, was a lab value called HbA1c. And the thinking was pretty simple. Lower the blood sugar, you treat the disease. But we've learned that that approach isn't just incomplete, it can be dangerously incomplete. Diabetes is not just a sugar problem. It's a profound cardiovascular problem at its very core.
All right, so here's the game plan for today. We're going to start with why this whole change happened in the first place. Then we'll meet the two new pillars of modern treatment, and we're going to call them the heart guardian and the artery protector. After that, we'll look at how you choose between them, and finally, check out the brand new playbook that doctors are using right now.
Okay, let's kick things off with just how massive this shift really is. We're talking about a move away from just staring at glucose numbers on a chart, and a move towards something much, much bigger: long-term survival.
And wow, the difference in philosophy is it's night and day. The old way was all about chasing that A1C number, trying to get it down, down, down. And look, that was a decent start, but it was only part of the story. The new reality, the new primary goal, is to put up a shield around the organs that are most at risk. We're talking about the heart and the kidneys.
So you might be asking, how in the world did this happen? Well, it all kicked off with a huge regulatory change back in 2008. There were some concerns that older drugs might actually be risky for the heart. So the FDA stepped in and made a new rule. Any new diabetes drug had to prove it wouldn't harm the heart. This was just supposed to be a safety check, right? But what happened next was one of the biggest accidental medical breakthroughs of our time. In these giant clinical trials, researchers found that two new classes of drugs weren't just safe, they were spectacularly protective.
Now, to really get this, we have to know what the scientists were looking for. They were hunting for a reduction in something called MACE. So what is MACE? Well, think of it as the big three of bad heart outcomes all rolled into one score: heart attack, stroke, and death from a cardiovascular cause. This became the new gold standard. If you could reduce MACE, you had a real winner.
All right, that brings us to the first hero of our story, a class of drugs called SGLT2 inhibitors. For our purposes, let's just call them the heart and kidney guardians.
So, how does this guardian do its job? It's actually pretty brilliant. These drugs work in the kidneys, and they basically help your body flush out extra sugar and salt in your urine. Now, why does that matter? Because doing that lowers the total amount of fluid circulating in your bloodstream. And the result? It physically takes a massive load off the heart. It's like taking a huge, heavy backpack off its shoulders.
And the results? Whoa, they were absolutely stunning. The big landmark trial for this class showed a 35% reduction in people being hospitalized for heart failure. And get this, this wasn't some tiny effect that took years to show up. No, this was a massive, life-changing benefit that kicked in within just a few months of people starting the medication. Incredible.
Okay, so let's recap Pillar 1. We've got the SGLT2 inhibitors, drugs like empagliflozin and dapagliflozin. These are your go-to guardians if the main enemy is heart failure, or you're trying to protect against chronic kidney disease. That's their superpower.
Okay, time to meet our second hero, the GLP-1 receptor agonists. If the first group were the guardians for the heart muscle and kidneys, think of these guys as the artery protectors.
Now, these drugs have a totally different playbook. Instead of messing with fluid levels, they go to work directly inside your blood vessels. They have these really powerful anti-inflammatory effects, and they seem to stabilize the dangerous plaque that builds up in your arteries. It's like they're calming everything down and putting a protective seal on that plaque, stopping it from breaking off and causing chaos.
And the results here? Just as incredible. A key trial for this class found a 26% reduction in MACE, and remember, that's the combined risk of heart attack, stroke, and cardiovascular death. This was a direct hit against the very things that cause these terrible events.
So wrapping up our second pillar, the GLP-1s, with names like semaglutide and liraglutide, these are the champions for anyone who already has established artery disease, so people who have had a heart attack or a stroke before. Their prime directive is to stop those events from happening again. And hey, that major side benefit of significant weight loss, that's a huge bonus.
All right, so now we have these two amazing new tools, a heart guardian and an artery protector. The big question is obvious, right? How do doctors pick the right one for the job?
And this table lays it all out beautifully. It's not about which one is better overall. It's about what specific threat you're fighting. If the biggest risk is from heart failure or kidney disease, you call in the Heart Guardian, the SGLT2 inhibitor. But if the main threat is from that plaque buildup, atherosclerosis, that causes heart attacks and strokes, then you deploy the artery protector, the GLP-1. And of course, there's a big practical difference. One is a daily pill, the other is usually a weekly injection.
But, we have to talk about a huge real-world factor here, and that's cost. As you can see, there can be a really significant price difference between these two classes of drugs, and that absolutely plays a role in access and decision-making for patients and for healthcare systems all over the world.
So, with all this groundbreaking science, the old rulebook for treating type 2 diabetes has basically been thrown out the window. Let's walk through the new playbook.
And the new thinking is just so much smarter, so much more logical. Step 1, you've still got your foundation. Metformin and lifestyle changes are key. But then right away, step 2 is to figure out the patient's specific cardiovascular risk. And step 3 is the real game changer. You deploy the right protector for that specific risk. And for the absolute highest risk people, you go to step 4, where you actually combine forces and use both for maximum protection.
And really, it all comes down to this one powerful idea. Treat to protect, not just to lower glucose. This is the new mantra. The goal isn't just about chasing a number on a lab report anymore. It's about protecting the person, protecting their future. It means organ protection now comes first. And this all leaves us with one last, really big question to chew on. For decades, diabetes has been seen as an endocrine problem, a sugar problem. But with these new treatments, which are so clearly focused on the heart, the arteries, and the kidneys, are we now entering a new era? An era where we treat type 2 diabetes as a cardiovascular condition first that just happens to involve high blood sugar? It's a huge shift in thinking, and honestly, it's saving lives as we speak.